Alaikum wa rahmatullahi wa barakatuh. Good evening, colleagues and friends from Middle East region. This is Dr. Suhail Al-Rukan from MENASO, chairing this webinar with our speakers and the audience tonight. I'm so happy that tonight is the 59th edition of MENASO Education Academy Cerebrovascular Grand Round Webinar. And today we are going to have 4 distinguished speakers. I'm so glad that we are merging the young generation with the senior generation, young blood with the more senior blood coming together. I'm so happy that we are having an equal ratio of 50 male, 50 female in our webinars. And this is one of the things that we keep in MENASO to engage the new generation, ladies in our webinars, new blood coming there with the senior people taking their wisdom. Today, I will be chairing this webinar with Dr. Nuran. Dr. Nuran maybe will be late tonight with us. So just to brief you a few things about this webinar, if you are the first time joining us with the 59 webinars edition that we have today, we will have 2 distinguished speakers, Professor Adel Hazani from Kingdom Saudi Arabia, and I will do the introduction for each one of our speakers during his presentation. Just I would like to highlight that Dr. Adel is the current president of Middle East North Africa organization, and he's going to give us a very nice presentation about unlocking potential for stroke ecosystem and evolution that they are doing in Saudi Arabia. Then we will have our second speaker, Dr. Alessandro Tirizo, who will speak about the recent advance in managing acute ischemic stroke patients. But before we are going to the 2 speakers, we will have 2 young neurologists who has a huge interest in stroke from Middle East UAE. We have Dr. Shahad Al-Hout and Dr. Noura Al-Khassauna. So we will start with the 2 cases, Dr. Adel, Dr. Alessandro. Then we will ask the 2 senior to present their cases. Just to remind all the audience that your question need to be added to the Q&A bar in your Zoom link. And also we will try to answer these questions by the end of the webinar. Second thing, there will be a CME hours, which will be sent within the 2 weeks after you submit your evaluation for this webinar. No further delay, I would like to introduce our first speaker, Dr. Shahad Al-Houti. Shahad is a neurology resident at Rashid Hospital, Dubai, UAE. Shahad is one of our distinguished residents. She is running stroke code in Rashid, and she's seeing many challenge cases. She's going today to present one of the challenge cases. Welcome, Dr. Shahad, to our webinar.
Thank you, Doctor. Good evening, everyone, and thank you for giving me the opportunity to share. I'm going to just share my screen, and please let me know if everything is working. All right. Is everything all right?
Yes, you can start.
All right. So I'm going to do a case presentation and review, and we're going to talk a bit about the topic of IV TPA in patients who are on DOAC. So we're going to talk a bit about a case that we had, and that prompted this literature discussion and further research into this issue. So let's first look at our patient. We have a 57-year-old male hypertensive diabetic obese with previous 3 CVAs that he completely recovered from. So he came with sudden difficulty with swallowing, groggy voice, and right facial droop. He had some imbalance falling towards his left side, but other than that, no other complaints. So on further asking about his medications, he did say that he was on Plavix. We specifically asked about anticoagulation, and he did not say that he was on any anticoagulation. We asked specifically multiple times, and he did not reveal anything from that. So we were a bit confident. We went to examine him. His NIHS was low, showing only partial paralysis, but he was having a groggy voice, unable to swallow. Gag reflex was negative. Palate was moving bilaterally. There was no pronator drift, no weakness, and everything else was normal, but CT showed opacification of PCA. And because even though the NIHS was low, he had dysphagia, and this is a disabling deficit. So in the recess, he was intubated because of respiratory distress and received tenecteplase. He then underwent thrombectomy, in which TK3 was achieved with stenting of the right V4 and basilar occlusion. We then shifted him to the MICU, and during his MICU, patient after MT was on aggrastat, and for almost a week. He had some mild oral bleeding, which settled. 24-hour repeat CT showed no hemorrhagic transformation, and so the patient was extubated. A few days after that, upon reassessing the patient, he had let us know that he actually was on anticoagulation. He some DOAC that he had been started on, and that he did take, and so that was new to us. And you know, it's kind of like shifted our focus on, oh, this patient had been on DOAC, and you know, current guidelines do not recommend patients who have been on DOACs for the past 48 hours to go for TPA, and this is what we had done in this patient. And that the good thing, there was no hemorrhagic or there was no bleed in this patient, but this prompted us to look into this a bit more. So as I said, current guidelines say within 48 hours, IVT thrombolysis is not recommended. That is due to two things: increased risk of the hemorrhage, intracerebral hemorrhage, in the setting of elevated plasma DOAC levels. And that's all based on pharmacokinetic principles, that the DOAC exerts a significant anticoagulation activity for up to 48 hours post-ingestion. And so these elevated plasma levels can theoretically increase the bleeding risk during thrombolysis. And so I looked at further data looking at the frequency of prior anticoagulation treatment in patients with ischemic stroke. And we can see that DOAC use is increasingly common among patients presenting with acute ischemic stroke, with up to 1/6 being otherwise eligible candidates for IVT, but they are taking DOAC at the time of the stroke onset. And a lot of them are atrial fibrillation patients that have potential eligibility for IVTPA. So one of the trial designs that I was looking at that is currently being run is the DO-IT trial, which is this large multi-center target trial that looks at the safety and efficacy of IV thrombolysis in patients who are within the stroke window and have taken DOAC within the past 48 hours. And that this study was showing that there was no great risk of a bleed. We're going to go into it a bit more. So the recent observation and registry data show that large multi-center cohort studies and international stroke registries, they show that in selected patients, IVTPA administered within the 48 hours does not result in statistically significant increase in the bleed or any major bleeding compared to patients not on any anticoagulation. And the functional outcomes, mortality rates are also comparable. And another thing that they notably noted, that the time from the last DOAC dose did not really affect the safety or efficacy outcomes in these studies. And meta-analysis and systemic review also said that, looked at the same studies and showed that patients on DOACs it's associated with a similar risks and rates of developing intracerebral bleed and mortality as patients on warfarin with INR less than 1.7 or those not taking anticoagulation. Subgroup analysis also by timing of the last DOAC dose and use of reversal agents showed no significant difference in hemorrhagic risk or early mortality, but it's also important to note that in these observational studies, they're subject to selection bias as these patients are selected, it's carefully selected patients, it's not given to anyone who's just on DOACs, all right? Okay, so this is a nice table, just a graphical data to show that these studies consistently show overlapping or nearly identical rates of symptomatic intracerebral hemorrhage and functional independence between the DOAC and the not anticoagulated groups, with no significant safety signal for increased bleeding risk or mortality. And that's what I wanted to re-emphasize that clinical decision-making regarding the IV thrombolysis in the patients, you have to tailor it to your patients, and even with confirmed elevated plasma level of DOACs, it should be individualized and weigh the risk of hemorrhagic complications against the potential benefits of reperfusion. And thank you.
Wow, very nice case. Tough case, unusual presentation. I'm not sure how you slept that night when you know that your patient is on anticoagulation that night. When did you repeat his scan to check if there's bleed or no? After 24
Actually,
hours?
he was intubated, so he let us know quite late, and he was on Acrostat as well. There was some mild oral bleeding, but other than that, we were lucky, and he did not have any bleed.
Okay.
So that's it.
So that's something nice. So just for the audience, this patient has been thrombolized despite we didn't know that he's on anticoagulant. The good news is there's no major bleed happened. And I believe our last speaker tonight, Professor Alessandro, will come across the new data about the new thrombolysis guideline and the advantage there. Thank you, Shahad, for the nice case. On time, 8 minutes. I'm so proud of you. Thank you, Shahad. We will go to our second speaker, Noura Al-Khawasna. Noura is a senior neurology resident in the same institute, Rashid Hospital, Dubai. I'm so proud of having Noura in my team in Rashid Hospital. Noura is very interested in neurology and in stroke. Currently, she's independently running the stroke code MT with the team of INR, and today she's going to present one of the challenge cases. Welcome, Noura.
Thank you, Doctor, for the introduction. So I will start by sharing the presentation. Is it showing?
Yes.
Okay. So since this case was a little bit new to our department, I name it the bright brain that went dark, a post-thrombectomy mystery. So our patient was a 59-year-old, non-diabetic, hypertensive, dyslipidemic. He had a non-STEMI in 2018, but did not follow up. He's having chronic kidney disease, and his baseline of creatinine is 2.6. He presented after being found with acute right-sided weakness and slurring speech at 8:30 a.m. He was last seen normal at 1 a.m., so it was a wake-up stroke. Prior to his presentation to our hospital, he was fully independent on aspirin 75 milligram daily, and he smokes 1 pack daily. He was bought around 2:19 p.m., which around 6 hours after he was found, and NHS was around 14 with dense right-sided weakness and severe aphasia. Just to highlight, his blood pressure and heart rate was within acceptable ranges, but he was out of window for TNK, and we proceeded for MT for that patient. Creatinine was around 4.2. So CT brain was around aspect of 7, and we can see here in the following images the changes, dense area around this area here, and CT angio. I will skip to the important part. There was a proximal M2 occlusion in the inferior division here, as we can see. Okay, and he underwent mechanical thrombectomy. His NHS post-MT was 12, TK3 was achieved. As we can see here, there's no perfusion, and after MT, it's all opened. So next morning, as I mentioned initially, NHS was around 12. Next morning, with the rounding team, he was found with global aphasia. NHS was 21. Urgent CT was ordered. So the image on the left, it's the on admission, and on the right is the post 24 hours. As we can see, we have hyperdense area on the left side, those at different levels. And we can see as if there's no stroke, it's only bright there. So is it hemorrhage? Is it contrast? Is it something else? We'll come to that. So as I mentioned, NHS was worsened, GCS dropped, so he was intubated, admitted to ICU, and the creatinine was managed because it was worsening, and he stayed prolongedly for 3 weeks in ICU until 31st of around like 15 to 17 days until 31st of October. He was extubated. GCS was around 12. He still is doing much better clinically, and he's still in our care, but he's still suffering from right-sided dense weakness and expressive aphasia. I just want to show you the repeated imaging. We can see on the left on admission, the post 24 hours, and on the right is on 31st of October. We can see the resolution of the hyperdense area. The infarction is established and it's more clear now. Those different images. So our patient was diagnosed with something called contrast-induced encephalopathy. It was the first time exposure for me as a resident to this like phenomena. I've never been exposed to it. So in the following slide, we're going to discuss about contrast-induced encephalopathy, what are the risk factors and how to differentiate it from hemorrhage and how to manage it. So it's a rare condition, and usually it's because of it's difficult to be diagnosed because of the heterogeneity and non-specificity of the clinical symptoms. Usually we expect it to occur from immediately to 24 hours post-contrast administration, and full recovery is within 48 to 72 hours. Although comorbidities might a little bit prolong the recovery, as we saw in our patient. So in our patient, our risk factors were chronic kidney disease, hypertension, large contrast load, and endovascular stroke therapy. So when I wanted to understand what caused contrast-induced encephalopathy. I came to different theories based on literature. They proposed the vasospasm and microcirculatory dysfunction after contrast administration that lead to cerebral vasospasm and impaired autoregulation. This lead to hypoxia and cytotoxic injury. The second theory mentioned that there will be shrinkage in the endothelial cells, opening of the tight junction, allowing contrast to lead to the brain parenchyma and leading to breakage of the blood-brain barrier. This leads to neurotoxicity, osmotic edema, and cortical irritation. Most of the literature that I found, they really accepted a blood-brain barrier breakdown theory for the CIE pathogenesis. Incidence is around 0.3 to 2% overall. It's also reported in around 40% in hyperosmolar ionic contrast, but also reported in non-ionic and isoosmolar agents, which are less neurotoxic. Its incidence around with stroke thrombectomy is around 1.7%. So what is the clinical symptoms? They will present with symptoms that mimic ischemic or hemorrhagic stroke, and as I mentioned, within 24 hours from the contrast administration. Usually they will come with altered consciousness, headache, visual disturbances, aphasia, amnesia, limb weakness, or seizure. There was a theory that they mentioned that CIE might resemble Press syndrome, and which is similar mechanism because of the breakage of the blood-brain barrier. And some other literature scholars, they propose that CIE represents a subtype of Press, which is triggered by contrast exposure. What are the risk factors? Hypertension, uncontrolled blood pressure impairs the cerebrovascular autoregulation that lead to endothelial stress, tight junction separation, and blood-brain barrier disruption. Chronic kidney disease, reduced renal clearance, prolonged contrast retention and exposure that will lead to more of neurotoxic agents. And type and osmolality of contrast. Older hypertonic contrast agents causes endothelial dehydration, widening of intercellular gaps, and destruction of the tight junction. Modern are less to cause this, but they are a risk factor for that. So here, this slide, we're talking about how to differentiate hemorrhage from contrast. So the HU value in CIE, usually it's around 90 to 120, which is iodine. In hemorrhage, it's around 40 to 60, which is blood. Distribution with CIE, we see cortical subarachnoid may extend beyond the vascular territory. As we can see in our patient, it was not clear. It was all diffuse, not to a vascular territory. In hemorrhage, it's confined to vascular territory or parenchymal bleed. The mass effect is minimal in CIE. It's really common in hemorrhage and resolves the CIE. We expect it to resolve with 24 to 72 hours. In hemorrhage, it persists and increase early. The dual energy CT is the one that differentiates. So we can see iodine MAM positive with CIE and persist hyperdensity. Sometimes CIE initially imaging can be negative, or does not show initially. can be normal. So, but that does not exclude CIE. Repeated imaging within 6 to 12 hours can relieve the evolving picture. So MRI findings, we can see cortical and subcortical hyperdensity. We can see on DWI and EDC, there's no restriction that can differentiate it from the acute infarction. On GRE and SWI, no blooming artifact, which can differentiate it from hemorrhage. T1 postgadolinium, it's a patchy cortical enhancement, which is transient. The management clinical course of CIE is usually beneficial with transient symptoms, and most cases improve within 48 to 72 hours. There is little evidence of optimal treatment, but close observation is advised, and IV fluid administration can be considered. Sometimes anticonvulsive therapy if the patient develops seizure and if needed. In severe cases, it has been reported that mannitol could be considered to reduce cerebral edema. The use of anti-inflammatory drug steroid is, however, controversial. And those are the resources. Thank you.
Wow, very nice. I can say it's very clear that this is a very rare condition. I'm not sure how frequent we are seeing these type of post-contrast encephalopathy in acute stroke setting. I remember when I saw the images after less than 24 hours, I said, wow, this guy is having a malignant MCA. There's a large ischemia. But when we did the MRI following, and our neuroradiologist, Dr. Saeed, was very clear that this CIA showed that there's no large ischemia. How's the patient is doing, Doctora?
He's much better. Now he's shifted out of ICU, is in the ward. But I believe unfortunately, the stroke is established. You still have dense right side weakness and expressive aphasia. It's no more global. Okay.
So before we're going to Dr. Adel, we have two questions for each one of you before your timing is finished. First question is from Dr. Aisha Munir. She's asking, in second case, did his CIE occurred as his kidney were compromised? Is that one of the theories?
Yes. Yeah. And when I reviewed literature, they found that intra-arterial contrast is at higher risk of having contrast-induced encephalopathy compared to any other contrast method. And the chronic kidney disease and the AKI over the chronic kidney disease was the factor that happened in that patient.
Interesting. Dr. Shahad, if you are listening here, there's a question for you from Dr. Sayed Hashim. Which type of NUAC did this patient was on, or DOAC, which anticoagulation he was on? Unmute yourself.
He did not specify, and we did not, like he said that he was on it and he was taking it, but he did not specify the name of it, just that he was given that. So I'm not sure, honestly.
Okay, so stay with us. More questions is coming for both of you by the end of the lecture. So thank you again for both young generation resident. Thank you, Noura. Thank you, Shahad. We will go now to our speaker tonight, Dr. Adel Hazani. Professor Adel Hazani is a professor of neurology at King Saud University and a consultant of neurology at King Khalid Hospital in Riyadh. Dr. Adel, I know him for a long time. Currently, he's the president of MENA Stroke Organization and one of the founders. Dr. Adel was the past president of Saudi Stroke Society, and currently he's the secretary general of Saudi Neurology Society. Dr. Adel is having a huge interest in stroke, TIA, headache, and he has more than 100 publication in a peer-reviewed journal. Dr. Adel also did his training in Canada and US. He's a neurointerventionist and he's an excellent educator. Welcome, Dr. Adel.
Thank you, Suhail, for your kind introduction. I'm not sure about all of that. And now I'm working in King Faisal Specialist Hospital. When somebody tell you about, talking about evolutions or history, you're getting old. And when Suhail was talking about junior and senior, I think he was dwelling in the same point. So I was giving this title to unlock potentials and talk about stroke ecosystem evolution in Saudi Arabia. I think of a lot of what I would say is going to be reflected on the other countries as well. This is a sponsored talk, and one of the things that I'll be talking about is the TNK, and it's not It's only approved in UAE, Egypt, and Pakistan, and it's intended for healthcare providers in those countries. This is an overview of my presentation. I cannot start a stroke talk without talking about the epidemiology and burden with a specific zoom in for Saudi Arabia. I'll talk a little bit about past, present, and history, historical landscape. What are the challenges in stroke care in Saudi Arabia, and what were the current paradigm shifts and future trajectory? So we all know that stroke is a major burden. It's the leading cause of adult disability and the second leading cause of death and dementia in Saudi Arabia and globally. And it's the third leading cause of death and disabilities combined. And each year, around 15 to 20 million develop a stroke. There is about 5 to 6 million deaths related to stroke. Recently, you've seen the world celebrating the breast cancer, and it just wants to emphasize that stroke kills more women than breast cancer and doesn't get the same or nearly close attention. And 1 out of 4 people are at risk of developing stroke during lifetimes. This is the Saudi Arabia metrics. It's, again, the second leading cause of death. There are around 25 new strokes annually, and if you combine those with the recurrence, it's going to come to 30,000 cases a year. Every 15 minutes, somebody is developing a stroke around the kingdom, and every 1 hour, there's a mortality related to stroke. It's responsible for around 8,000 disabilities, and this is expected to increase by 50 to 60% over the next 10 years. We all know that stroke, if left untreated, half the patients will be severely disabled or dead, and 2/3 of the patients will be left with disability. And in addition to the disability, which we usually focus, the impact of stroke extends beyond that to the lives of the patients and their caregivers. Significant impact in quality of life, not only for the patients, but to the caregivers, in addition to the neurological manifestations that we heard. Like in the previous 2 cases, there's other, like, say, fatigue, mood changes. And as we said, 2/3 of the patients will have some sort of disability in the stroke survival. And there is economic and productivity impact and psychological impact. Some highlights of the economic impact. The direct cost of stroke worldwide is close to $1 trillion. It's around $900 billion US dollar. This is around 1.12% of the world's GDP. This was in 2017, and you would expect that the numbers are now even higher. The estimated loss of household income due to stroke is around, also again, close to $1 trillion. It's 976 billion US dollar internationally. And the mean cost per patient, the cost of stroke in high-income countries is somewhere between 30 to 60,000 US dollar, and similar figures from Europe. Now, when I was, a medical student and starting my internship, there was time where stroke thought about as hopeless. In Arabic, we say "falij la tu'alij." So it was not uncommon for stroke patients in certain hospitals. They would, not even image them at night. They would keep them in a bed on the side. Some actually might start aspirin, and this is still a practice in certain parts of the world, even before doing the CT scan, because the majority of stroke, as you know, they're going to be ischemic, and they think, they're going to be doing more good than bad. And believe it or not, in the Green Journal before the NIMS trial, there was about 50 to 60% of stroke patients not assessed for the 24 hours. So there was, limited recognition, limited awareness, and subsequently, this leads to increased mortality and morbidity related to stroke, and even access to things like, supportive care and rehabilitation was very, very limited. When I came back out of my practice, there was only, handful stroke centers around the region, and thrombolysis was administered to only very, very, very few patients. So Suhail usually used to say, they used to treat them with the 2 whites or al-abidain. So, blankets and aspirin, and that was about it. But we came a long way since then, and there are now more and more interventions that's proven to decrease mortality and morbidity, including the reperfusion therapy, thrombolytics and mechanical thrombectomy, admission to stroke units, secondary prevention measures, and rehabilitation. This is for those who develop a stroke. And of course, always the primary prevention, as 90% of stroke can be preventable. This is the map of Saudi Arabia when you put it against Europe, and it would cover 14 countries. So it's a huge country. And as I mentioned, when I came back, there was lack of public awareness of stroke symptoms and signs. There was limited numbers of stroke units. When I returned from my training about 15 years ago, there was only 2 stroke centers. And there was less than 10 stroke neurologists in the country. There was no training program for stroke for physicians or even nurses. And you can imagine the geographic proximities to stroke centers was a challenge. The window for intervention was very, very limited. At the time, thrombolysis was with the first few hours, and mechanical thrombectomy was only done infrequently. And of course, because there was a complexities in diagnostic and decision-making that requires expertise, access to acute stroke interventions was very, very limited. Now, looking back at the historical or landmark trials, streptokinase and urokinase came in early 90s, and it was adopted initially by the cardiologists. Then the aspirin trials came back in late 60s and 90s, which shows, giving aspirin to stroke patients, is better than nothing. The major landmark, which caused, major transformation in the stroke care, was the NINS trial, which came in 1995, where for the first time we started to have, effective treatment for a stroke. Then the 2 large aspirin trial came, and more thrombolysis trials tried to explore the window beyond the 3 hours. And in 2008, the ACAS-3 trial came, which extended the window beyond 3 hours to 4.5 hours. And I feel that, it was during the time of my fellowship. This just tells you how old I am. But, the major landmark studies is kind of intertwined through my journey. And then the ICE-T3 trial, which is a large pragmatic trial, tried to expand the indication for thrombolysis, looking at those who were excluded from the ACAS-3 because their stroke is severe or because of age. And it showed that, those patients would benefit from the treatment. However, it failed to show that window can be extended beyond 4.5 hours. And then the largest transformations came with the major thrombectomy trials in 2015 in the international stroke meetings in Nashville, with the simultaneously publication and presentation of Mr. Clean, Escape, Extend IA, Swift Prime, and Revascat. Just to highlight that, in the 90s also, the data about stroke units came, which showed that it decreased mortality and decreased dependency. The number needed to treat to prevent one bad outcome was 1 in 10. So reduction in mortalities and dependencies, and decreased length of stay, decreased complication by up to 60 to 70% in some reported literature, and decreased length of stay and increased dependence. I still believe that the stroke unit is the heart and the cornerstone of all stroke intervention, and interventions can be provided to all stroke patients, hemorrhagic, ischemic, early comers, late comers. Still, we are all excited about the acute and reperfusion therapy, but even at the best centers, this is only provided to a small percentage of stroke patients. I just wanted to highlight that the advantage of NINS trial, that in addition to showing that you have an effective treatment for acute stroke, is it changed actually the way we look at stroke from, hopeless, untreatable, to now treatable disease, where, neurologists, they become more proactive, where you need to adjust your system, where you're going to have a rapid response and stroke code and an in-call team, which really helps not only patients who receive the thrombolysis, but other stroke patients, people were attending to them, and because they were assessed earlier. And although we start treating patients in the first 3 hours and then 4.5 hours, we learned very, very quickly that the earlier you do it, the better. We know that time is brain, and if you do this at hospital level or even at regional level, as it is in this study that was published in Alberta, where they decreased door-to-needle time from 70 minutes to 40 minutes, they improved their outcome and discharge home by 15%. So just by adjusting your system, having more efficient system, and we've seen this replicated in many, many countries, and the best example is from Helsinki, where they dropped their door-to-needle from close to 2 hours to less than 30 minutes, and of course it's improved the outcome. As I mentioned, the second revolution in stroke care was the mechanical thrombectomy, where you have high chances of reperfusion, up to 90%, and number needed to treat of 2.6. This is very robust treatment effect, almost unheard of in medicine. And as I mentioned, when this data was published, the New York Times Magazine, thought about this revolution that resembled the discovery of penicillin because of the efficacies of these interventions and how much can transform lives and improve outcome and reduce disability. After thrombolysis and thrombectomy, systems of care try to adjust it to be more efficient in diagnosing and treating those patients. So we started to hear about terminology of door-to-needle, door-to-puncture. But one thing still consistently high is the onset to door. As we need to do more work in the pre-hospital phase to increase the awareness and perhaps to deliver the care earlier. And I just wanted to highlight this. This is the data that was presented about the decades of improvements door to puncture times from the American Heart Association. Now, moving forward, so I talked about the initial data from 60s and 70s to 2015, and going forward from the mechanical thrombectomy landmark trials in 2015. Now, the shift was going from time window to physiological window to try to include more patients with large vessel disease. So the DAWNS and DIFFUSE trials showed that you can treat patients with large vessel disease up to 24 hours. And then we started to talk about large core and, treating them even very, very late, which is now the focus of select late. So we're moving from rigid time window, and this is a paradigm shift from going with time to surrogate marker of the time or using image to try to offer the treatment for larger population of the patients and using some AI softwares. So what happened is that the systems, starts to work, as I mentioned, to develop within the hospital some metrics and KPIs. This was until 2015 and 18, and I'm talking about Saudi Arabia and the region. We started to have more and more of stroke centers, stroke units. The numbers, I would say, went anywhere from 5 to 10 times. Like in Egypt, it went up to 100 units. But again, those centers remains silos. As you see, this is a picture from Al-Ula. You see Qasr al-Maid. It's likely not connected. So now the other paradigm shift was to developing networks. And just to put this in relations to what's happening in Saudi Arabia, in 2017, the healthcare was going through transformation, and the Minister of Health here, Dr. Tawfiq Rabi'a, announced the new model of care in Saudi Arabia. And this is the outlook or the design of the model of care. And you can see it has 6 layers and 6 systems of of care. The layers of care has the patients at the center, and you want patients' well-being rather than, you know, health and well-being. You want to keep them healthy and safe at home. And then you have different systems of care, of interaction with the health system, starting from, you know, activated person, healthy lifestyle, to healthy communities, to virtual care delivery, to primary health care, and at the last is a specialized care. Now, there was times where most of the care delivery was happening actually at the tertiary care centers. You know, people, when they have anything from colds to, you know, stroke or MI, they will run to the emergency. And this is something slowly shifted towards the community and home. And you can see the systems of care starts from, you know, safe birth to late phase, both spectrum, and from, you know, keeping well and preventions to urgent care, and you know, chronic care versus planned care. And the focus for acute stroke therapy is in the urgent care. And around that model, you know, I was lucky to be one of the people who works on the acute care model, trying to develop the standard and the policy. At the time, we worked very, very closely with the people with acute coronary syndrome and traumas. All those diseases were time sensitive. And when we put the standard, national standard, we specifically put there that no patients in the kingdom should be more than 30 minutes away from stroke experts, or an hour from primary stroke centers, or 90 minutes from comprehensive stroke center. Now, this is very, very challenging. So allow this to be land or air, and for stroke center or stroke expert, this can be done also virtually. This is for the, and then we started talking about stratifications of, you know, acute stroke ready to primary stroke center and comprehensive stroke center. And as you know, as we're developing the standard and disseminating it to health clusters, which is geographic responsible hospitals, that's assigned to population in the region. So the kingdom has around 14 or 15 clusters distributed across all the geographic regions of the kingdom. Then COVID hit it hard everywhere in the world. And if there was advantage for the COVID, it's, you know, it was the era of, you know, telemedicine, you know, adoption. And you can see the utilization and publication about telemedicine after COVID. And, you know, telemedicine had been utilized way before COVID. As a matter of fact, we had a proposal in 2014 for National Telehealth Network. But as you can see, when there was a priorities, it was when COVID hit, this where, you know, everybody started to use telehealth. And stroke is uniquely situated for telemedicine because it's a, you know, there is gaps, and it's a national health problem and burden. And we talked about wide geographic and population distribution. The expertise were in the large cities. There is clearly visible clinical findings, and there was well-established data about, you know, efficacy and safety of telehealth and teleassessment. And we have effective therapy, so it can be utilized to increase utilization, in particular because there was a narrow therapeutic window, and as I mentioned, limited specialist availability. In 2019, there was 3 stroke networks, 2 within the Ministry of Health, and 1 was within the private sector, and all of those networks progressed rapidly. You know, I was fortunate to work with Dr. Saeed Al-Zahrani, who's shown here in the picture, to start the pilot phase of the virtual medical center at the time, which became Saha Hospital. We started with 2 remote hospitals in Al-Baha and Jizan. And you know, we try to use different system locally built in and teledoc. And those hospitals never, some of them, they don't have neurologists, never administered thrombolysis. They didn't have a protocol for stroke. So it was not only connecting to hospital, but also capacity building and training people. And Saha Virtual Hospital vision was to be a leading global example of delivering and promoting virtual digital healthcare models. And they wanted to provide transformative healthcare through use of innovations and modern technology. And those are their values. And currently, they are the world's largest virtual hospital. This is a standalone virtual city that sits in the digital city of Riyadh. And now they're connected to over 150 patients. Now, stroke is part of that. They do teleradiology, tele-ICU. They do, primary healthcare, psychology, rehabilitation. And I think there is a long, long list. And I haven't been working with them recently, so I might miss some numbers. But this is the typical dashboard. When you're working there, you see the hospitals and you see the metrics. I believe now they're connected to 65 hospitals around the kingdom. You can see their TPA utilization rates at this dashboard was around 18%. Now I think it's higher. Their door-to-needle is 28. This virtual hospital also helps during time of Hajj to be connected to different hospitals. Some of those hospitals are temporary for different sites in Hajj. So at the time they were connected to 10 hospitals, for example. They have 11 physicians covering, and their door-to-needle in Hajj was around 25 minutes, which is, if you know the logistics of Al-Hajj and the numbers of population and number of patients being seen in ER, this is quite challenging to achieve those numbers. So kudos to Dr. Saeed Zahrani and his team. Now, I talked about thrombolysis, and we know that the TPA, as I mentioned, the NENS was a landmark and transformative study, but TPA has its limitation. One of its limitation is the very short half-life, so it's given as an infusion for over 1 hour. And during the time, as I said, when you need to transfer patients or when you don't have the nurses to adjust the infusion, sometimes if you transfer patients with TPA, there is requirements for special ambulance or to have a special team. This happens in Europe and some provinces in US, but also for us here, because we serve as a hub hospital. And I know if the patient's going to be taking TPA, it's going to add 30 to 45 minutes of delay. Although we are saying, drip and ship, but, adjusting the, the pump and, taking care of all logistics cause significant delay because, as I mentioned, sometimes you need specific trained staff for transfer. And of course, the adverse effects, including intracerebral hemorrhage. This is the, historical development of alteplase from the, time where it was approved in STEMI back in the 80s. And as I mentioned, the, FDA approval for use following that was for PE, and then stroke came in 1996. But again, it was only approved in Europe in 2002, and I believe in Canada around 2003. But there was a slow adoptions between, the NENS trial to being in practice for many reasons. One of them is as I mentioned, the narrow therapeutic window, the contraindication, and the lack of the centers. Now, TNK came, about 10 to 15 years after, and initially, similarly, it was first used for myocardial infarction. I believe it was used in 2000. Initially, was approved by FDA. My first patient to receive TNK was during my, I don't know if Suhail remembers this, during my residency, where by mistake on one of the hospitals we were serving to consult, the ER physicians gave them TNK instead of alteplase, and I couldn't sleep that night. Luckily, the patients did well, but the trials about TNK and stroke, I think, starts around between 2010 and afterwards. I think Dr. Terrazzo is gonna, highlights more about this. But in 2024, it was approved in Europe, and earlier this year in March, it was approved by US FDA for use in acute ischemic stroke following ACT trial. When I look back to numbers of stroke, as I mentioned, when we start the model of care and trying to analyze our metrics, we have between 25 to 30,000, 25,000 first stroke, and if you add the recurrent stroke, about 20%, it's going to come to close to 30,000. Only 20% of those patients arrive by AMS. At the time, there was only 5% of those goes to stroke units. TPA rate was less than 3.3%, and there was less than 200 to 500 mechanical thrombectomies around the country. Now, the aspiration was, that all majority, if not all, of stroke patients end up to stroke units, to increase our IV thrombolysis to 25%, and to increase number of thrombectomies to 5,000. And doing the economic analysis, if we were able to establish this, this means that you can save, or you can obtain functional independence in close to 20,000 patients, 18,000 patients. And majority of those are actually patients with large vessel occlusion, which is typically moderate to severe stroke deficits. So if we do the metric analysis, this is work by Dr. Asnani, Al-Jahani, and myself, that 18% of more patients that will regain independence, there will be fewer patients with severe disabilities, and you will improve survival rates. Not only you will improve clinical outcome, but actually you're going to save money. The estimated cost saving in the next 15 years is around 600 million, about 255 million is related to direct costs, and more percentage, of course, around 350, and indirect costs. This reflected in productivities gains and reduced caregivers burden and support. And this is the projections of the amount saved in Saudi riyal. So in 10 years, you're estimated to save around 1 billion Saudi riyal. And in the 15 years, you're going to save close to 3 billion Saudi riyal. So you're not only improving the system, improving outcomes, and helping more patients to become independent and reduce mortality, but also you're saving money. So the strategic implications and policy recommendation was to investment prioritizations. And if you are thinking like investments, I think the return of investments on this is really big, with, as I mentioned, clear return on investments for stroke care enhancement system. And, it requires systems integration. And we also recommended following that you need to implement early, because you can increase, in a way, your projected cost saving, and improve outcomes will be even higher. Now, moving forward, so about a year ago, King Faisal Specialist Hospital got the first mobile stroke unit. It's been operational now for over a year. And the last webinar, Dr. Fahd Al-Ajlan and his group tried to highlight their experience with mobile stroke units. One of the things that we did is we repurposed the mobile stroke units for the first time to use it for mass gathering in Al-Hajj, which is a unique way of thinking how to use it. And I'll talk about the mobile interventional team as well. So for those who who were not here last week, or last webinar, the basically mobile stroke units is I consider it an extension of the emergency room, where where it has a CT scanner, capacity of doing basic labs. In our mobile stroke units, we can do CT and CTA. We have tele capabilities, but we also have physicians, critical care nurse, tech, and the basic medications needed for acute treatment of stroke, including thrombolytics and reversal agents for intracerebral hemorrhage. In our mobile stroke units, they have even a delivery kit if it is needed. One of the things, as I mentioned when I was talking about telestroke, I've talked about the utilization in the pre-hospital and in ED, but now it's utilized throughout the spectrum. Half of my stroke prevention clinic is done virtually. We use it in rehabilitation and in outpatient settings, so it can be used throughout the spectrum of stroke care. Now, where are we moving from here? Tailoring preventions and treatment strategies based on genetic, biological, and lifestyle factors. Right now, in stroke preventions, we utilize NMR, which show us a better precision for diagnosing hyperlipidemias for those small particles. And cardiology literature showed that half of those patients with dyslipidemia is not picked by routine testing. We're utilizing pharmacogenetics, and now we know that at least 1 in 5 of our patients are clopidogrel resistance. We utilize it also to choose which best statin to use. Biomarkers driven diagnosis and prognosis models. We're now working on using polyomics, including metabolomics and transcriptomics, and even microbiomes to see who are those who are at risk. How can you adjust your stroke prevention strategies based on metabolic and inflammatory shifts? Refining advanced imaging and individualized treatment. We're utilizing AI applications for better selection, and maybe this will become relevant for MEVO, for example. We're obtaining 7 Tesla MRI, which perhaps would help us to, again, refine our treatments and diagnosis. AI assistant clinical decision supports, for example, digital twinning and multiple inputs for risk predictions. We moved from measuring outcome by MRS only to patients reportable outcome, and this is commonly collected for our patients. Machine learning models to predict strokes, and I know Dr. Nouran was supposed to be with us. They have more than 5,000 inputs for individual patients. This is from visits to activities to sleep to dietary habits to wearables to dental health to predict who are those at high risk. Now the Ministry of Health flags those with 2 or more risk factors to perhaps have more visits, to mandate more visits to primary health care through digital applications they use. As I mentioned, utilization of AI imaging, not only to detect stroke and LVOs, but perhaps to better selections of patients, predict outcome. I've talked about personalized risk assessment tools to guide prevention and integration of all those data and machine learning, perhaps that can help to tailor not only treatment for individuals, but at the population levels. Where should you sit your stroke centers? How you're going to use algorithms to move patients from one center to another? What's the best way for utilizing the mobile stroke units? The ambition is to get 2 more mobile stroke units, and we are trying to work to see what's the best model to be more efficient to operate those. Innovation, we always talk about acute stroke care, but even in rehabilitation, you've seen robotics and skeleton care, and I just wanted to mention that there is a big interest in innovations in rehabilitation. Just 2 weeks ago, and I want to highlight this, our hospital performed the first robotic intratumor resections, and now we're thinking about remote neuro intervention, especially with limitations of expertise in the peripheral regions. Now, when our colleagues interventionists go to locums in remote areas, sometimes they would stay there for a week or 2 with limited number of cases. So this is not the best utilization, and we know that as I mentioned, that the mechanical thrombectomy is core interventions for stroke care. And our access percentage is currently around 10% based on the empty glass data. So one of the things we're trying to adopt, and again, this is very, very early, is remote neuro interventions. We have 2 of our stroke interventionalists have been trained and certified for this. But again, this is a work in progress. It's still not ready for prime time, but we might see this in a couple of years. This is the work of Dr. Mohammed Al-Jahani for those remote and rural areas to improve access, is what we call mobile interventional team or flying interventional team, where they're working on, developing algorithm to move the interventional team from one of the closest big regions with interventionalists. This is Eastern, Western, or Riyadh. And they have, the full sets. There'll be the neurointerventionist, the tech, and the nurse, where they're gonna, fly. Of course, we tried the other way around, but we noticed that with the longer transfer of the patients, there is the percentage of utilities is high. So this is something Dr. Al-Jahani is currently experimenting and piloting. So hopefully we'll hear soon about it. So I hope I was able to show you that stroke care in Saudi Arabia has evolved remarkably from limited recognition, limited centers to organized systems. And I think the next era is going to be defined by precision, prediction, and personalization. We're moving from populations to personalized medicine. I think collaborations, technology, and patient-centered innovation will drive future success. And I think together we can unlock the full potentials of stroke ecosystem. Thank you very much for listening. I'll be happy to take any questions.
Thank you, Dr. Adel. Wow, you covered a huge area going from the old age of stroke care to the too white, now to the more advanced treatment. And I can see the change that Saudi Arabia over the last 10 years, 15 years did with the stroke. I remember when you started there, the number of thrombolyzed patients, limited number of stroke unit, limited number of stroke expert, and now the number is going up. There's a training centers for a stroke. There's a multiple comprehensive center. The care that you are providing during the Hajj time, during the big meetings in Riyadh or Jeddah or Mecca, the innovation with the stroke unit, the innovation virtual stroke code that you are running in different cities. These are something I admire that you and your team, the names that you mentioned in your presentation, I highly appreciate the work that they are doing in the kingdom and at the level of the region. I would like to mention that for all our attendees, there will be the Q&A bar. You can put your question there. And thank you, Dr. Adel, again for the unlocking the future of stroke care and the ecosystem that you built.
Thank you, Sahel. Just to clarify, perhaps I'm the least one to contribute to this. This is a huge work of a group, and I'm just here to tell the story.
And that's the leadership. I'm so happy that I'm working with you, Adel. Thank you again. So we will move again to the the third or the fourth speaker tonight, Professor Alessandro Tirozzo. Alessandro is a senior consultant. He's a professor of neurology he's a senior consultant. At the same time, he's working at Mediclinic City Hospital as the head of department and the clinical lead and the head of the Mediclinic Comprehensive Stroke Center at City Hospital in Dubai. Professor Alessandro underwent for a specialty training in Milan for neurology residency program, and he did his master in the cerebrovascular disease. He's one of the few people in the GCC country expert in ultrasound for the neck and ultrasound TCD, and he's a good teacher in this field. Also, he's running very busy clinic in the private sector in Dubai, and today he's going to speak about the recent advancement in managing acute stroke patients. Welcome, Dr. Alessandro.
Hi, good evening, Dr. Suhail. Good evening, everyone. Thank you for the invitation. And first, let me complement with the quality of the talks and the amazing lectures we heard so far. The cases from your team, Rashid, were really interesting, and Professor Adel show us a amazing journey in stroke care in Saudi. We all have to learn from that. So now, without further ado, let me share my screen. Can you see my screen?
Yes, we can.
Okay, so we're gonna talk, and we'll try to not to take too much time because of the late hour, about the recent advancement from alteplase to tenecteplase. I will show some of the key points and why it works so well for us at Mediclinic City Hospital Stroke Center, and some additional data in large core treatment. Of course, the main point of stroke treatment is to try to avoid the evolution of the core, represented, for example, in CT perfusion on the right as the red area, into a full established stroke, trying to save the penumbra, the green part, before it becomes too late, revascularizing through thrombolysis or thrombectomy. And we've been doing this with alteplase for the past 15 years or so, and now recently we were able to start using tenecteplase. It was approved by the EMA in Europe in 2024, and in 2025 recently also by the FDA. And in the UAE we've been using it since early this year. These are just a view of the clinical trials that allowed implementation of alteplase first and tenecteplase more recently. And as you can see, from 2010, 2012, the first trials on tenecteplase were published, leading to the publication of the pivotal trial and the approval of tenecteplase also for stroke acute management. So what are the guidelines saying about tenecteplase coming from alteplase? The European Stroke Organization guidelines on the left-hand side are stating that for patients with acute ischemic stroke in the 4.5 hours window eligible for thrombolytic treatment, tenecteplase 0.25 milligrams per kilo can be used as a safe and effective alternative to alteplase, 0.9 milligrams per kilo. Evidence is moderately strong, and the strength of recommendation is very high, strong recommendation. And among the experts that were reviewing the guidelines, 9 out of 9, so all of them, were voting in favor of tenecteplase 0.25 milligrams to be used instead of alteplase for patients with acute ischemic stroke in the expected window of 4.5 hours, thanks to the safety and efficacy data collected so far, and also because of the advantage of the bolus intravenous infusion over 5-10 seconds compared to the 1 hour infusion that is necessary instead for alteplase. And if this is true for patients with stroke based on CT scan, for example, it's also true for patients with documented large vessel occlusion with an acute ischemic stroke in the window of 4.5 hours, eligible for thrombolytic therapy. The ISO panel recommended tenecteplase instead of alteplase for patients with LVO and acute ischemic stroke in the 4.5 hours window. There is a comment for wake-up stroke because we don't have enough data yet, and there are no enough data for tenecteplase to recommend it, although the experts in 9 out of 9 again vote, they recommended, they consider tenecteplase as a reasonable alternative to alteplase, but those patients need the selection with advanced imaging, perfusion, or MRI perfusion investigation before being eligible for any kind of thrombolytic therapy. And about the American Heart Association guidelines, for the AHA guidelines, it's reasonable to choose tenecteplase instead of alteplase, again at a dose of 0.25 milligram per kilo for patients that need thrombolysis and are candidate for mechanical thrombectomy with a level of evidence of 2B. Now, why tenecteplase is as much as possible and anytime as possible taking over alteplase in thrombolysis for acute ischemic stroke, because it offers several pharmacokinetic advantages over alteplase. So tenecteplase has a longer half-life of 22 minutes compared to 3.5 average, but 3 to 5 minutes of half-life of alteplase, meaning that with a single bonus, it will stay in the bloodstream and perform for way longer compared to alteplase. This is also the reason why you need a smaller dose of the molecule itself, only 0.25 milligrams per kilo instead of the 0.9 milligram per kilo of alteplase. And the treatment duration allows the bolus infusion of only 5 to 10 seconds instead of the bolus plus 1 hour infusion of alteplase. And the pharmacokinetic behind this is based on the greater fibrin specificity, which is 15 times higher for tenecteplase compared to alteplase. So it's more specific for fibrin, but it's also more resistant to the inactivation caused by the PI1, which is 80 times more resistant. So get less inactivated and it's more specific and allow to spare more fibrinogen compared to alteplase, leading to less expected risk of systemic bleeding because of the more conserved amount of fibrinogen. So comparing the two molecules, because the mechanism of action, alteplase initiates local fibrinolysis by binding to fibrin in the thrombus and converts the entrapped plasminogen to plasmin. Tenecteplase, it's a third-generation genetically engineered variant of alteplase with more fibrin specificity, more resistant to inactivation from the plasminogen activator inhibitor with a longer duration of action. Both are metabolized by the liver, but the other advantage is not only the longer half-life, is that the terminal excretion rate is 90 to 130 minutes compared to alteplase. And what about the data? Is it really as effective compared to alteplase? So all the data we collected so far, and I will show just a few trials for the sake of time, showed absolutely, without any doubt and with absolute confidence, that tenecteplase is non-inferior to alteplase. And as you can see in the ACTA phase 3 clinical trial, it was documented the non-inferiority of tenecteplase compared to alteplase in terms of the primary outcome. That was a modified ranking score of 0 to 1, so excellent outcome at 90 to 120 days after a stroke. And all the patients received either tenecteplase or alteplase, acute ischemic stroke in the 4.5 hours window from the onset of the symptoms, achieving excellent outcome in 18% of the cases in both arms. And the dose system was based on the body weight in the 4 intervals of less than 60, 60 to 70, 70 to 80, 80 to 90, or more than 90 kgs for tenecteplase. The other very relevant and key clinical trial was the Extend AI TNK trial that was instead addressing thrombolysis before thrombectomy. So those were patients candidate to mechanical thrombectomy, documented at neuroimaging with an acute ischemic stroke, also eligible for intravenous thrombolysis. So patients were randomized either to tenecteplase or alteplase before going the cattle for the mechanical thrombectomy. And the beauty of this data showed that patients that were treated with tenecteplase were having a higher probability of having reperfusion and recanalization just after thrombolysis, even before receiving the thrombectomy. So the primary outcome was the reperfusion of more than 50% of the involved ischemic territory, or absence of any retrievable thrombus at the initial angiographic assessment before the mechanical thrombectomy. And as you can see, the patients that were treated with tenecteplase achieved the recanalization reperfusion of more than 50% of the territory in 22% compared to only 10% of the alteplase arm, showing there were significantly higher probability and odds of achieving recanalization even before thrombectomy if the patient were treated with tenecteplase instead of alteplase. Not only, the extended EI trial also documented that patients who were able to achieve this reperfusion more frequently compared to alteplase were also achieving a better functional outcome. So not only better angiographic findings, but also better outcomes. And this is the slide that shows the improvement, so the better 90 days functional outcome after tenecteplase treatment compared to alteplase. So the patients had were able to achieve a modified ranking scale of 0 to 2 in a way larger proportion compared to those treated with alteplase. And you can see tenecteplase at the top and alteplase at the bottom. Now looking at the one of the meta-analysis, one of the many meta-analysis that verified through the different clinical trials safety outcomes. So we have seen that the efficacy is comparable, actually is even better for patients with LVO. But what about the safety from and through the different clinical trials? So patients receiving tenecteplase at the approved dose for ischemic stroke, which is, let me repeat it again, 0.25 milligram per kilo. All the meta-analysis shows similar key safety endpoints for TNK compared to alteplase. There were the same number, and so no increased rate of symptomatic intracranial hemorrhages with the TNK compared to alteplase. And also there was the same number of fatalities, so there was no increase in the mortality rate at 3 months for patients treated with TNK. So same safety as alteplase, but better results in case of large vessel occlusion. I wanted to show you some more recent trials, just two, about TNK compared to TPA, the ATTEST-2 and the original trial. There were very large trials, one UK-based, another one Chinese-based. They both demonstrate, again, non-inferiority of tenecteplase compared to alteplase, but actually better results because of the increased practicality of the bolus infusion. The ATTEST-2 trial saw more than 1,777 patients randomized in this open label trial run in the UK of TNK versus alteplase, single bolus against bolus plus infusion in acute ischemic stroke in the approved window of 4.5 hours. And tenecteplase was non-inferior again to alteplase for a functional outcome at 90 days. With rates of excellent recovery, so the 0-1 ranking score, independent recovery, similar between the two groups. And again, for safety, comparable rates of symptomatic intracranial hemorrhages %, and the same rate of mortality or extracranial bleeding between the two arms. In this case, the study patients were also potentially eligible to mechanical thrombectomy, and endovascular treatment was offered in 12% of the patients, showing the same rate of reperfusion. The original trial, 1,465 patients, multi-center trial run in the Chinese population across 55 stroke centers, again investigating tenecteplase versus alteplase for non-inferiority in the window of 4.5 hours. And again, tenecteplase showed to be non-inferior to alteplase for the excellent outcome at 90 days, so 0-1 at a ranking score. And safety also was confirmed with the incidence of symptomatic intracerebral hemorrhages and net-case mortality, similar between the two groups with no differences. And there were no differences between age or sex, baseline NHSS, and comorbidity stratification. I would like now to share with you a small sample of the experience that we've been building up with Tenecteplase at Medical Lake Comprehensive Stroke Center. We are officially we are the only private hospital in Dubai certified as comprehensive stroke center, together with the governmental Rashid Hospital as the other only comprehensive stroke center of the Emirates. And we started using Tenecteplase from the late spring time, so around end of April, beginning of May. I just want to show you the data about 2 months, May and June, where we were able to candidate to intravenous thrombolysis 13 patients, and I wanted to share with you the door to intravenous thrombolysis that was recorded, highlighted in blue. Only in 3 patients we were not able to have less than 45 minutes door to IV TNK. One was intubated basilar thrombosis case. It was very challenging and life-threatening emergency. And the other 2 cases were difficult to manage and difficult to have the agreement from the family to go ahead for thrombolysis, although this is standard of care. These are the cases that were candidate also to make a thrombectomy after intravenous thrombolysis, and we were able to achieve a TK3 or TK2B score in all of the candidate patients. And after candidating and treating these patients with intravenous thrombolysis with Tenecteplase, we did not record any hemorrhagic transformation post thrombolysis or thrombolysis plus thrombectomy. And I also wanted to highlight the NIHSS at discharge. If you compare the NIHSS at admission, you can see that basically only in one case there was a very minor change from 14 to 12 in NIHSS, but majority of the patients had a dramatic improvement of the documented at the National Institute of Health stroke scale, and also the ranking score at post-discharge reassessment showed excellent outcomes in nearly all the patients. Only one patient had a persistence of a high ranking scale. All the other achieved a 0 to 2 ranking score at 3 months. This is our protocol. This is what we do currently in our stroke center. The moment the patient is triaged as BFAST positive, or if we receive pre-notification from the national ambulance system and the patient comes with already a positive BFAST, we immediately activate code stroke, which is announced as a loudspeaker. So the CT scan is kept free, and all the team members, they immediately reach the emergency department, and we go for, as per protocol, immediate CT angio, and CT perfusion for all our patients. At the same time, because the code stroke is announced, we receive a notification also on our mobile phone for neurology and radiologist, and of course the ED doctor. They activate at the same time. We collect NIHSS, and we receive through rapid AI mobile real-time notification about CT with aspect score, and then CT angio, and then CT perfusion, so we can in real time assess the case even if we are not physically present and available immediately in the emergency department. And we candidate the patient to intravenous thrombolysis. We bring the stroke box with TNK directly in the CT room, so in the radiology department during the CT, and immediately after having the CT scan done, if it is negative for hemorrhagic lesions, we provide intravenous thrombolysis, if possible, even before the CT angio. Then we proceed with CT angiography to document eventual presence of large vessel occlusion, and analysis of the CT perfusion data based on the onset of the stroke. We can candidate to even extended window mechanical thrombectomy, and we bring the patient directly to the cath lab for the for the endovascular procedure, and then we admit the patient in the stroke unit beds in the ICU. And we start the journey of speech, physio, occupational therapy assessment, cardiological, diabetic, endocrinologist, and nutritional assessment for the post-stroke management. I want to share with you this data because these are real data, and we have to be realistic and share what we are really doing, not only what comes from the clinical trials. These are our data before 10K with TPA. We are not doing great. We are having an average of 60 minutes door to IV TPA. It was always given and provided after CT angio, after coming back to the emergency department. The infusion of 1 hour was always taking a lot of our time, and the performances were not great. But you can see in 2025, these are 2 months, the same 2 months, so May and June for 2023, May and June 2024, and May and June 2025. And as you can see, after transitioning from alteplase to tenecteplase, our door to needle dramatically reduced from 60 minutes to nearly 30 minutes. And apart from a couple of cases where the thrombolysis was started after 50, a majority of the patients receive intravenous thrombolysis in 20, 12, 11, 30 minutes maximum, with an average time of 34 minutes, which not only led to quicker thrombolysis, but also to better functional outcomes, as you've seen before. This is the reason why, because when you have to give alteplase, you have to start diluting the medicine in the 2 small bottles. You open it only when you're sure you can start it, so not to waste money. You wait until the CT angio are done, and you've got the green light to proceed. Then you have to transfer the solution in the bottle. Then you have to start the bolus, and then to start the IV line for the infusion of 1 hour. Movements of the arm, the infusion gets blocked because the patient was moving. There are many things that can go wrong, or they can just delay the thrombolytic therapy based on alteplase. And with tenecteplase, you basically are able to remove all these obstacles in your race against stroke, because you just dilute tenecteplase and you inject as a bolus over 5 to 10 seconds. Always remember that you're not using the cardiological dose or syringe. We are using only the approved preparation for stroke, which has a different dose. So this is why it's so important to remember. And these are basically the advantages. It's easier and quicker to administer. We do not need the infusion pump anymore. We save a lot of time to needle and to eventually to transfer. The dose is quickly administered, so it does not also slow down the process of transferring the patient, for example, to the cath lab, as it has a very simplified protocol, which makes everyone's life easier. It reduces also the chances, the possibility of having errors between the doctor, the nurse, the dreaded dose calculation chart, even if you do this by calc or by your system or the computer. You've got all these numbers. Many things can go wrong when you're picking up the dose of alteplase. With tenecteplase, we can just use the 5 windows, so we can give 15 or 70.5 milligrams, 20 milligrams, 22.5 or 25 milligrams, which is the maximum dose based on the body weight. And again, body weight is very challenging. The family will tell you 1 weight, and then you measure on your scale or on your bed, and you got a different weight. The patient has clothes and shoes. There are so many things that can make the dose not very accurate when you are administering alteplase. This way, with tenecteplase, you are really sure that you are providing the right dose for your patient range. And this was also documented. I showed with you our experience, but this was also documented in the trials. This open label study, for example, showed a consistent and dramatic reduction in the door to needle time after transitioning from alteplase to tenecteplase. And the door to needle time target of providing intravenous thrombolysis in less than 45 minutes showed superiority of tenecteplase over alteplase, with more than 40% patients were achieving this time compared to less than 30% on alteplase. And on average, the tenecteplase thrombolysis can save at least 6 minutes per patient. This also allows a faster transfer if the patient is going to be treated in a primary stroke center, for example, and we need a thrombectomy in a comprehensive stroke center that is not available in the same facility. And the clinical trials also documented a reduction in the door in, door out time, so the idle time in less than 90 minutes when you treat patient with tenecteplase 37% of the times compared to only 14% when treated with alteplase, with a 22 minutes faster median door in, door out time when you're using tenecteplase versus alteplase. You're sparing nearly half an hour in saved brain cells. And just one slide about the large core and intravenous thrombolysis with tenecteplase. This was from the French registry. It's a recent publication, 2024, more than 600 patients with anterior circulation large vessel occlusion. So ideal candidates, but with a large ischemic stroke, which are less ideal candidates. And the large ischemic core was documented at aspect MRI base of less than 5. Normally, we say it's safe to go for treatment aspect 10 to 6. We become more concerned when the aspect is lower than 6. So these were patients with a large core. But in the appropriate window, very high NIHSS, 19, median age 71, a median aspect of 4, so very high risk population, treated with intravenous thrombolysis, followed by mechanical thrombectomy. And as you can see, even in those patients, the tenecteplase was associated with better 3 months functional outcome and lower 3 months mortality compared to alteplase. And the rate of parenchymal hematoma or symptomatic intracranial hemorrhage were similar between TNK and alteplase. There was no excessive bleeding risk, but less mortality at 3 months. And reperfusion was achieved in 83% of the cases. Monitoring after thrombolysis with tenecteplase is the same. We have to follow the same rules as with alteplase, so you should target the same blood pressure in order to safely start intravenous thrombolysis with tenecteplase 185/110 to be eligible, and then you have to maintain 180/105 during and after thrombolysis. You have to check NIHSS every 50 minutes in the first hour, every 30 minutes for the next 6 hours, and every 1 hour up to 24 hours as with alteplase, and you monitor for the same risk of complication, bleeding, or lingual angioedema as with alteplase. So going to the conclusion, intravenous thrombolysis is still the first line of treatment for ischemic stroke. The introduction of tenecteplase improves time to needle and improves functional outcome, especially for those patients with large vessel occlusion needing a mechanical thrombectomy. And we will gather new data for out of the window, low NIH case, and these data are being collected, and we'll see probably an update in the guidelines very soon. I thank you for the attention, and I will stop sharing my screen to go back to Dr. Suhail and the...
Thank you, Dr. Alessandro. Wow, great work in your institute. I'm so proud that tenecteplase made some changes for our patients by decreasing the door to needle. That's very clear. And I'm so happy that you had few cases, 16 minutes, less than 20 minutes. That's indicate how efficient is this team. One of the things that I admire that when the TNK came to the UAE market, the teaching that we had and the training for our team showed the efficacy of doing a new treatment innovation. Just a very quick question before we end, because we exceed our time for tonight. How did you manage to do that transformation from alteplase to tenecteplase? Did you do it abruptly? Did you train your team? Just in 2 minutes, just tell us how you did that.
Sure, very quickly. So we started the training and the teaching way before getting the medicine on board. So we started actually 3 months before with core meeting with the neurology team, the emergency department, and then the nurses, because everybody has to be trained. So you don't have surprises. And this was done through lectures, videos, and examples of bringing in the medicine itself, so you can see how to prepare it to avoid the mistake of using again alteplase or using the cardiological dose of tenecteplase, which has not to happen. But the moment you are able to transition, my recommendation would be make a full and complete transition. So move completely over from alteplase to tenecteplase. Don't keep both for stroke at least. Of course, you can still use alteplase for other indications, pulmonary embolism, whatever. But for stroke, don't keep them close at all, and prepare the stroke box only with 10K for stroke to avoid any mistake. And looking at the questions box, cost tenecteplase is less expensive than alteplase, so should also bring a financial advantage to the hospital. This was one of the concerns. And in terms of who is giving thrombolysis in our setting, yes, we trained our consultant ED physicians to provide thrombolysis if you're not physically in the hospital yet. They start giving thrombolysis indirectly in the ED, directly in the CT scan room. Yes.
Okay, so at the end, we are tonight 5 minutes more than our target time. I would like to thank Professor Alessandro for his excellent talk, nice journey, nice way of changing the gear toward the more innovative treatment. Dr. Adel Hazzani answered his all questions there are more than 12 questions was there. He answered them. Thanks for Professor Adel. And I would like to thank also my two resident, Dr. Shahad Al-Hout and Dr. Al-Khawasna, for their excellent 2 challenge cases. Our audience, I'm so happy tonight to meet all of you. We are reaching our 5th year of this series of webinar. I'm so glad that we are doing good at the level of the region, and I'm sure that this will add some to your student and to your stroke team. Make sure that you will be able to do your evaluation, so you will be able to get your CME within 2 weeks. And remember, next month there will be another update in the stroke, and please keep spreading the word of stroke fast in your region, and tell your student to share their challenge cases with us, and we will be more than happy to present it on our webinar.